So we'll start the first.
So we'll do case 1, case 2, case 3, no?
Okay, sure.
This is
First case,
one,
yeah.
Case 2,
So-
case 3.
So the first case, the audience in this row has to give their comments.
So, good afternoon, everyone. For the next 1 hour, we are going to cruise through a series of cases, and it will be a collaborative discussion from the panel of experts. I welcome Dr. Vimy, who is our lung transplant specialist, who will pitch in relevant cases, and Dr. Jennifer, who will pitch in when palliative care is needed. So the aim is to give a flavor of how MDD works and mirroring the real world scenarios. So the first case. Mr. JR, a 73 years old, known asthmatic for 30 years, with worsening of his cough for 3 months, and exertional breathlessness of grade 2 MMRC with an effort tolerance of 1 kilometer. He had history of dryness of mouth, in that for several years he has been swallowing food with water. But he denies any dryness of eyes. There was no joint pain or no other significant exposures. He had other comorbidities like CKD, gout, and diabetes. He did not have any overt external signs of CTD. Chest examination revealed bilateral scattered V's. And labs revealed ANA was 1+. Echo did not show any evidence of pulmonary hypertension. This was his pulmonary function testing, which showed obstruction, and the lung volumes were pretty preserved. There was no air trapping, but there was reduction in DLCO, and there was significant desaturation from 96 to 91% on 6-minute walk test. So,
good evening, all. So that first set of people are the ones who will be talking about this CT. You can just shout out, but I know there is one of our fellow is there, so that fellow don't have to shout out the findings. The others can tell about the findings. So chest radiograph, anything obvious seen? Anything? Yeah, just shout it out. Yes or no? Anything obvious? Not obvious? Okay, just... Increased reticulation, I probably won't accept that because I think it's a little difficult to say that for sure.
Bilateral hilar prominence with reticulations in left lower zone seems like.
This hilar prominence is a little vague terminology, but I don't think it is there. Do you feel? When do you call it as hilar prominence? Okay. If you ask me, I would say nothing very standing out because it's not very obvious. I mean, I think when you go a retrospective view, you may find some findings, but nothing obvious as of now. Okay, let's move to the CT sections. So I'll just first scroll through these images. I'll try to put both the axial and the coronal. I'll first scroll through the axial. So remember all these cases, it's important first to see the whole thing. Don't go just one finding and come to diagnosis. Just go through all the findings and then try to come to the diagnosis. Let me just adjust the window. Yeah. Okay. Now all these cases we already have discussed. You have seen images from morning. There were multiple sessions where all these were addressed, so it should be easy. And already you have good clinical history, which is already pointing towards something. So with that in mind, you should look into this. I think afternoon also we had a session. Morning also it was addressed.
Anyone can speak up. Unless you speak up, you will not hear. There are so many in this room. Please speak up. Otherwise,
It's okay to make mistakes, but at least what is the main finding? What is something striking?
So cystic lung.
Okay, cystic lung disease. That's great. Now you just have to put them which cystic lung. Name some of the cystic lung disease you know of. Okay, LCH,
Lamb.
LIP. Okay. So now you saw sir had put in that nice table also. You remember that? So now you try to put it into that. See, radiology is all about just putting the patterns in, and trying to. And now you have a good clinical part and the physiology, and now you just have to put it into it. So what is it? So where are these cysts? Or what kind of cyst?
Paraseptal emphysema.
Pardon?
Paraseptal emphysema.
Somebody said perivascular, somebody said paraseptal emphysema. So you saw in the morning, Dr. Aparna showed the difference between the paraseptal and the other cysts. So the key finding for emphysema is the imperceptible wall. Okay. So here you can see a defined wall. So that paraseptal emphysema is not correct. What else? Someone said perivascular cyst. Sorry, my... Okay, I think my mouse is not moving, but still we can, okay, I'll come there. But so what kind of cyst among the LAM and LCH? LAM, what kind of cyst you will see? Uniform. Is it uniform? So this is not uniform cyst, right? Okay, we'll see the coronal. Coronal, its things are. So where is the location? Location-wise, it is. So the question one, if suppose you didn't have the clinical history, anyway, this is not evenly distributed cyst, right? So the other thing what you can think of is LCH. But in the history, was there anything for LCH? We didn't have. Now location-wise, where is it located? Lower lobe predominant and along the vascular bundles, isn't it? So this is very typical for perivascular cyst. Okay, what else you can, so once you think about perivascular or once you see perivascular, what comes to your mind next? LIP. So then you can also look for other associated findings are there or not. It needn't be there all the time, but you can look for it. What are the other things you will look for? GGOs. Consolidation, not common. Like if you look at the literature, there are studies which had shown very small percentage, but those are not the common things. GGOs, very few times you can see reticulations and the cysts. So always from the cyst, you can go and look for the other things. So in this case, we didn't have much of faint. If you look at it, it's probably faint ground glass in some areas you can see, but otherwise not much. Sometimes it will be like a centrilobular nodules which are of ground glass attenuation, which I think for you to figure it out may be sometimes difficult. In certain areas, very small, tiny ones are there. But the main finding is perivascular cyst. And we decided it is LIP. Okay? I think that is the main radiology part to it. Yeah.
Okay, what is the next step?
Kavita wanted to ask a question.
Yeah.
Used to take water to swallow food for quite some time is what the history said. So that history is pointing towards this. So in the auto antibody profile, what else do you want to look for? Yeah, what will be positive if it is Sjogren's? Anti? SSA?
So
Next.
further workup revealed row 52 was strongly positive and SSA was 200. He also underwent a minor salivary gland biopsy from the lip, which showed a focus score of 1.
Dr. John Matthew? Okay. What's the role for salivary gland biopsy? Do we really need it?
I'll just make a couple of comments. Rarely you make a diagnosis of Sjogren's in men because the ratio is almost 10 to 12 is to 1, or 9 to 12 is to 1. Second is, actually 5 people here are ANA positive in this group, and 15 to 20% of men over 70 are ANA positive. And almost 25% of elderly people are Zika symptoms. It's because of the degenerative changes in your salivary gland. So these are all the background. So he's like a male, and he's on the other side of 50, and dryness can be like many other causes. Particularly, I would check whether he's on any anticholinergics. So all those things are there. But actually, by American European classification group criteria, you need 5 points. That's a classification criteria, but it has a sensitivity of about 95%. Like, you know, so 95% of in 100 you are right. It has if you have a score of 5, there's a 95% chance that you pick up a Sjogren's. So if anti-SSA positivity has a score of 3, somebody has a dry mouth, it has a score of 2, or dry eyes, it has a score of 2. So automatically fulfills criteria. So generally, you don't need both lip biopsy and SSA. If somebody is SSA positive and he has Zika symptoms, you diagnose it. But, you know, I will be wary because of the other reasons. And sometimes, you know, you find atypical immune-related problems like, you know, antibody positivity. You have to think whether it's like a paraneoplastic process. Or, like, you know, I think, like, why should a 73-year-old man get a Sjogren's syndrome? So is it like a whole process is paraneoplastic?
Comments regarding further treatments? Audience, how do you treat? Anybody in this row want to make it's open to other rows also.
If moderate to severe symptomatic, again immunosuppression has to be given.
So immunosuppressive treatment, you want single agent, dual agent? Okay. MMF needs to be there. Other immunosuppressants can be added. Okay. Any other comments?
Do you think that if 75 or 73-year-old patient is a good candidate to give immunosuppressives? One. The second thing is, if we recollect the spirometry reports, his FVC was almost 90%, FE1 was 90%. So there is no significant physiological, at least a dysfunction. And similarly, he was able to walk at least 1 kilometer. So quality of life, physiological parameters, and this seems normal. And considering the age, so I'm reluctant to start immunosuppressives.
Okay. So, I mean, immunosuppressions is one part of treatment, but the other part of treatment is his other measures for his swallowing difficulty, dry mouth, and others. Do you have other slides for this patient? How he was treated? Yeah.
Finally, this was the diagnosis.
We should more focus on the symptomatic treatment instead of directing to the underlying disease.
He had troublesome cough, which was in which palliative care was involved.
So he, in spite of all the treatment, his main symptom was cough. Whenever he enters his room, he will cough, and he will cry because of his cough. And we had a difficulty. We started treatment, even with immunosuppressive treatment, his cough will not go away. So I'll open the discussion to Dr. Jennifer. She is a palliative care, palliative medicine consultant. So for her comments on intractable cough in this patient.
Thank you. So Cough can be a very distressing symptom, and in qualitative studies in patients with ILD, they have defined that as overwhelming and pushing them to a lot of psychosocial issues, and carers also saying difficulty sleeping. So sometimes our focus can be on what to do to get the disease better, but at the same time simultaneously or parallelly to look at symptom management is very, very important. So opioids have been used for, and most of them have dry cough. So if there is first thing is always any symptom, look at any reversible causes. So many of these patients also have GERD. GERD is almost present in more than 95 to 100% of patients with ILD. So in which case you need to treat them with address GERD. If the cause is primarily because of the disease, and despite treatment symptoms are troubling, opioids are a standard of care for treatment of refractory cough. Actually, recently, I think January 2024, Lancet had a double-blinded crossover trial, again with low-dose morphine for cough, and showed good benefit. So opioids, small-dose opioids, 5 milligram BD is what they used in that study, very useful. As whenever you prescribe morphine, also prescribe laxatives and antiemetics, because we want them to take it and we want the symptom to be under control. The other things which have been used are neuromodulators like gabapentin, nebulizations.
In addition to that, we had 2 other causes for his intractable symptoms, which we, during the initial admission, we didn't recognize. It was oropharyngeal candidiasis. So when we saw his whole throat was full of white patches, so we had to treat it with fluconazole. So another thing, the initial admission, he had only high resolution CT scan. Subsequently, when we did a CT pulmonary angiogram, because he was so symptomatic, we found that there was a big pulmonary thrombus, which was quite surprising. He didn't present acutely, but that is one of the reasons for his intractable symptoms. So your eyes of vision, your horizon should widely look for why this patient is not improving in spite of all this treatment, because all these things can get overlooked, because you have an obvious cause for his cough, but you have to look widely. We'll go to the next patient. Yeah.
Why did he get pumped through? Was it investigated? Why did he get
we didn't investigate. We thought that it is because of the connective tissue disease itself. Pardon? Yeah. So we had a malignancy screen. There was no obvious cause for as a paramalignant cause of this thing. And subsequently, over next 3 months, his cough completely subsided. Now he's off his morphine. He was on gabapentin as well for his intractable cough. So all these was subsequently weaned off over next 3 months.
We also saw. So, we actually presented this patient's report management in one of our palliative care conferences. But our team saw him, and literally we saw the improvement in quality of life when symptoms are better. So I just want to reiterate that symptomatic measures is what improves quality of life and psychological burden. So we are doing a study with severe ILD patients, and we are seeing approximately 40% of patients are having anxiety, and 50 plus patients are having depression while screened on the HAD score, and that can be contributed by several things including symptoms. Thank you.
Next please.
So case 2, Mr. PM, 51 years old, who presented with a cough for 2 years with scanty mucoid sputum and exertional breathlessness of grade 2 MMRC, however had a effort tolerance of 2 kilometers. There were no CTD symptoms or no significant exposures. He suffered mild COVID in 2020. He had a family history of respiratory diseases. His sister died of interstitial lung disease. He had grade 2 clubbing and JEP was not elevated. There were fine basal crepitations. His CTD profile was negative. There was no evidence of pulmonary hypertension. His pulmonary function testing showed restriction, and there was reduction in TLC. There was no air trapping. DLC was, however, maintained, and there was no significant desaturation in 6-minute walk test.
Yeah, so what do you find on the chest radiograph? Okay. You can speak loud. Okay. Anything else?
Small nodular or reticular nodular opacities.
Okay. Yeah.
Diffusely.
Okay, so bilateral reticular nodular opacities. Anything else? How is the costophrenic angle?
Oh, right CP is obscure.
Yeah, right side seems slightly
Diaphragm
blunted.
is
Doesn't always means it has to be effusion. It could be also thickening. Okay. I think those are the main findings. How is the cardia? So always in the ILD, we know that, there could be associated pulmonary arterial hypertension. We should also look at the pulmonary bay, the cardiac chambers. Is there any enlargement?
Left pulmonary artery is.
This is not the straightening what we usually call. Left pulmonary artery always will be descending pulmonary is often seen as a retrocardiac shadow. We cannot really see the caliber. We usually look at the, if you have to measure, it's the right descending pulmonary which looks normal in size. So the question comes whether is it centralized or not, centered. So basically we look at the medial end of the clavicle. So we mark it, make the distance, measure the distance from the spinous process to the medial end of the clavicle. So if there is a difference of more than 10 millimeter, we call that side the patient is rotated. So as Sir has said, there is a mild rotation towards the left side. But still, even with all those mild rotation, which I think will be seen in a lot of our cases, because most of our patients may not be perfectly able to, especially when they have symptoms. But I would say that cardia is not enlarged. I think the main finding is the reticular nodular opacities. Okay, so let's move to the CT, and then I'll show the CT and you can, oh sorry, I think it's 2 is enough. So I'll scroll through it first. So this is the top part from the craniocodal aspect I'm moving. Okay, I'll show the coronal also. So always remember all the diffuse parenchymal lung disease, see the whole thing together and then comment on the pattern. So when we're looking at the pattern, we look at all the predominant findings. Don't look at one small finding and get deviated. Look at the overall findings and then try to put things together. So if I'm showing you like this, okay, which pattern do you want to say? Or what are the things which is striking your eye?
GGOs with traction bronchiectasis.
Okay.
Apicobasal gradient is there.
Okay. So is it like, is there a sparing of any lobe?
The lower lobe predominant disease.
Lower lobe predominant.
Okay, but there is no lobar sparing. Everywhere it's involved. And how is it? Is it like very heterogeneous between the, is there a symmetry between the two sides or is it quite asymmetric?
Symmetrical.
More symmetric. Okay, so ground glass is there, tractional bronchiectasis, and what is there between the ground glass? All these areas, what you called? Okay, other than the tractional, these are the what we call the so-called reticulations. Cobweb-like appearance. That's where what we call the reticulation. So there are ground glass densities, reticulation, there are tractional bronchiectasis. So where do we want to put? So then what comes to your mind when you are seeing something like this?
Yes.
What are the things you want to rule out and then put things together?
This pattern, NSIP.
Okay, so someone said NSIP. Why not UIP?
No honeycombing.
Okay, so that is one thing. So all this, when you see diffuse parenchymal lung disease, fibrosing ILD, the two main common things what you will be always, is it NSIP, is it UIP? Okay, so you are looking for honeycombing. Is there honeycombing anywhere? So here we can see some focal area of subpleural cyst. So don't commit this as, so there was a question asked earlier, somebody, whether a row of but here it's a very focal, so don't commit this as honeycombing yet. We have only very focal area. So that's why it's important to look at the whole CT together. So the predominant thing is still the tractional bronchiectasis. Of course, in a very few percentage, the fibrosing ILD, fibrotic NSIP can evolve into UIP, but that's a very smaller percentage. But here what we are seeing is predominantly the tractional bronchiectasis. We have ground glass densities, reticulations, which in some areas are quite irregular. So what is the diagnosis? There's no honeycombing. So
mixed fibrotic and cellular NSIP? No.
Okay, so you are saying mixed NSIP with both components. That's what you meant. Okay, so that is that I would say is correct, because we still have some areas, though that's not the predominant, where there is no tractional bronchiectasis, at least in some areas, but already a lot of tractional bronchiectasis has already come in. I agree it is a mixed. There may be a little bit proportional variation. It's not like maybe not 50-50, maybe a little more fibrosis has already set in. So this is more of NSIP pattern with a lot of fibrotic changes. So when after finishing that, always look at the other components, like whether we have a diagnosis. Also look at the main pulmonary artery, measure it. We can, so if it is more than 29 millimeter, we'll call it as pulmonary artery is dilated, though there's some studies do take up to 32 millimeter, but routinely we take 29 millimeter as a cutoff. And there are also, what are these? Some small lymph nodes. It could be most of the time reactive. Now there was one finding which I don't know whether somebody had noticed it. Yeah, so when you see this, what comes to your mind? What are the things you should rule out?
NSIP, OP,
yeah, so one, we can call it as an overlap, but before that we should rule out an infection. So that is clinically we should rule out, and lab-wise we should rule out a overlapping, we should rule out infection. If it is still persisting, then we can raise a suspicion for an overlap. I think in this case we didn't call it as an overlap because we had the follow-up. I think this was probably related with an infection. So other things are, as I mentioned, look at the pulmonary artery. Also look at the esophagus. Is it dilated here or not dilated? Not dilated. So we have seen cases in the morning where we have seen some dilated, where we can go towards the etiology, or at least we can raise a possibility that whether a scleroderma is there. So this one, it's a, so that is, so the important key things to remember is look at the whole picture, see what are the predominant findings, and then try to put the which pattern it fits in. Okay.
So what you want to do is, so we have a patient with fibrotic NSIP pattern, a focal shadow which we need to rule out infection. Suppose we have ruled out infection, what do you want to do next?
Autoimmune serology.
Autoimmune serology. We have
autoimmune serologies are negative.
Negative.
HP panel exposures.
Is there?
No history of exposures, and radiology was not typical of HP.
Anything else you want to do? Drug history is not there?
No drug
Genetics.
history.
Genetics. Why do you want
died,
genetic testing?
Sister died of ILD, I think.
Yes, there is a family history in which sister died of some lung disease. So here comes the importance of genetic testing.
So genetic testing was done. He was found to have MUC5B and surfactant protein A1 mutations positive detected. So the final diagnosis made was familial interstitial lung disease, and the pattern was fibrotic NSIP.
So when do you do
Mixed
genetic
NS.
testing in ILD? One is family history, yes. Other than that?
One or
Young age, yes. Then? Lamb, okay. Hermansky. If there are other organ involvements like skin involvement in Hermansky, Pudlakin, or diskeratosis, Congenita. So in that condition also skin involvement will be there. Or hematological abnormalities, platelet dysfunction, all those things, if it is there, which happens in Hermansky, Pudlak, albinism, all those are there, we should think of some genetic causes and do the genetic testing. Anything else you want?
Multi-organ involvement, which suggests some syndromal kind of involvement. In that case, so in those cases, we should go for genetic testing. And young age, family history, in this case, so directly there is a family history. At a very young age, sister had died, so that means there is something which is going on.
How, Dr. Vimi, any familial ILD, have any patients who had lung transplantation?
We evaluated for short telomere syndrome. So that was a 35-year-old female with a ILD running across generation, but this patient presents with recurrent episodes of embolism. Then the serial lung function was declining. So one thing what I want to tell was the role of pulmonary rehabilitation, because I understand whatever we say about pulmonary rehabilitation, the reality is it doesn't happen much into the practice. So other than immunosuppression, any patients who is diagnosed an ILD should have upfront the role of pulmonary rehabilitation exercise prescribed. And it would be very nice, because I have seen in this center how they prescribe the pulmonary rehabilitation with the booklet and the specific prescription for individual. And it is something which really improves. So other than the immunosuppression, the role of pulmonary rehabilitation and even the palliative care. Everybody thinks that the palliative care comes in the picture very last, but it is not the current recommendation. I think palliative care consultation should be done whenever required, because it gives a tremendous improvement of the symptoms. So it all should work hand in hand.
Did you say that you send physiotherapists to their home to make sure that once in couple of 2 times a week?
Yes. So once the patient is diagnosed as an ILD, whether they are listed or not listed for transplant, so we have the upfront pulmonary rehabilitation prescription that is given, and every 2 days one of our physiotherapists goes to their home to understand how practical about the prescription what we given is happening. Because most of the time what happens is we give a prescription and patient comes back after 2 weeks telling that I am really fatigued and I cannot do. And it just takes a few things, like we have patients whom we give the stand up, stand down and step up, step down exercises, and minimal, just the small bottles for endurance exercise of the upper limbs and small weight for the lower limb exercises. So it is all about how they are following up after a pulmonary rehabilitation prescription is given, and how much, because we can really feel that a patient on 4 to 5 liter of oxygen having a tremendous good quality of life, and towards the 65 to 70 where we are little in a dilemma whether you should really go for a transplant or not. And these kind of measures and the home physiotherapist, palliative care really makes a huge significant role.
So I think I totally agree with this. So there are two aspects. If you will include this pulmonary rehabilitation with your medicines, the effect will be multiplied. One thing. Second thing is, once we have told there may be genuine problems for patient coming back to your rehabilitation center. So to overcome that, what we are doing at our institute is we have started video rehabilitation. So we have a group, patient is enrolled in that, and in a group session there will be, and they will keep on doing, and we keep on observing on a WhatsApp group, and if somebody is not doing, then we can reinforce the need and what mistake they are doing. So I think that can be one way how we can overcome the obstacle which we are facing during this.
Thank you very much. So we'll go to the next case.
Next case, Mr. M, a 67 years old male who was diagnosed as fibrotic hypersensitive pneumonitis in March 2022. Based on his PGN exposure and HRCT showing typical of fibrotic HP, he was diagnosed with a moderate confidence. And he was on inhalers, prednisolone in tapering doses, and was on LTOT. In Jan 2023, with 2 months of worsening breathlessness, he presented to us with increase in his grade from 2 to 3. And he also had reduced effort tolerance to less than 100 meters. He also had worsening of cough over 2 months. There were other comorbidities were CLD with portal hypertension and diabetes mellitus. He had grade 3 clubbing and he was dyspneic and saturating 93% with 2 liters, and he had bilateral fine crepitations and squeaks. CTD profile was negative and echo showed no pulmonary hypertension. And this was his complete pulmonary function testing. In March 2022, he had 69% of his FVC, which dropped by 18% in Jan 2023. There was also a drop of 15% in his DLCO, and there was a drop of about 180 meters in his 6-minute walk distance. Radiology for discussion.
So comments from this row, X-ray.
Bilateral interstitial haziness, bilateral reticular opacities involving all lobes, all segments.
So, okay, you mentioned bilateral reticular nodular opacities.
The right pulmonary artery might be thickened.
Okay.
Dilatation of the...
Okay, mild prominence is there. Okay, I think that's kind of probably is the main finding. In this case, we already heard the history, the scenario provided. So this is of March 2022, that is before he came here. This is the previous one. I think from May 2022 is when the thing was presented. So this is the one prior to that. So I'll just show the axial and the coronal images. So in this case, it's a little more easier for you because you already know the diagnosis, but I want you to tell what are the findings you are seeing. Because you know the 8 years criteria, now we use the fibrotic, non-fibrotic from 2020. So what are the findings you are seeing in this case? I think this similar picture was also shown some 2-3 times today.
Head cheese.
Okay, let's start with, when you look at here, what is happening here?
Upper lobe.
Upper lobe predominant fibrotic changes, isn't it? And what is happening in the lower lobe?
GGOs and...
GGOs are there. Okay, some tractional bronchiectasis, yes, that is there. What are these very darker areas, sir?
Air trapping.
Air trapping. And also some normal looking areas. And this is the triple density sign, which previously was called as a head cheese sign. So this is a very classical features, all the typical features of fibrotic hypersensitivity pneumonitis. Okay, now let's move to the next. Okay, I'll just show side by side. So this is of December and this is the March.
Progressively fibrosing.
Okay, progressive pulmonary fibrosis. So why did you say that? What did you say?
Honeycombing has increased and there are new onset GGOs.
New onset, just GGOs, will you call it as progressive fibrosis?
No, the additional to the traction.
GGOs with?
Traction bronchiectasis.
Reticulations or traction bronchiectasis. And here you can see all the size of this traction bronchiectasis has increased. And in some areas, the extent also has increased. So either the extent has increased or the size of the tractional bronchiectasis or honeycombing, if it's present, if that is increased, or if there are ground glass, previously ground glass densities which is now replaced with fibrosis, or GGOs with new onset of reticulations or tractional bronchiectasis, or if the overall size of the lung has reduced, or the nodules or the opacities are becoming more confluent, or so all these you should think of progressive pulmonary fibrosis, and this is very typical. You can compare both the side by side and you can see the difference. So this is progressive pulmonary fibrosis. You can see the honeycombing also has increased in size. Okay.
So now we have a patient whose symptoms have worsened, PFT has worsened, and radiologically it has worsened. So what do you call it and what do you do next? Exacerbation. So here, when you say exacerbation, so it will be predominantly GGOs or consolidation. So here it is fibrosis also increased. So it is, you cannot call it as exacerbation. So you'll have to call it as a PPF, progressive pulmonary fibrosis. So what do you do next then?
We can counsel for a transplant.
Transplant, okay. Next.
And
medication-wise?
Medication-wise, increase the steroid and antifibrotic. You can add antifibrotic.
You can add antifibrotics. Okay.
And already he was in steroid, can increase the dose pulse therapy. And of course the support O2, LTO2.
Okay. So oxygen therapy you suggested, pulmonary rehabilitation, consideration for transplantation, agreed. Add antifibrotics, agreed. What about steroids? Should we give steroids or not? Any comments? What?
So one thing is we need to check whether patient have taken the standard of care or not previously before labeling progressive pulmonary fibrosis. This term is only used when you are sure that patient have already taken treatment. The second thing is regarding that somebody said that it is exacerbation. So by definition, exacerbation is defined when duration of worsening is less than 1 month. Here it was 2 months. So we should not make that kind of mistake. Regarding treatment, I think concept-wise, the all non-IPF ILDs, there may be some kind of autoimmunity playing in role. So I will say that probably inflammatory process going on that has increased the disease. Somebody can say, no, it is only fibrotic process which have increased the disease. And I'm pretty sure there will be few patients where both things are going simultaneously. So till now, there is no modality to say with high level of confidence that there is no autoimmunity playing role or inflammation playing role in these patients. So even today I don't know whether these patients first we should hike up the immunosuppressants or we should only give antifibrotics or should we combine both. So this is my understanding. I have no answer to this, but I have just started a project which has been approved by ICMR. We are conducting a multi-center trial to see all these drugs which will be effective. Maybe next year when we meet somewhere, I will be able to answer this.
Dwivedi, you want to make any comments?
We can hike up the immunosuppression and see the response first. And then we can add on nintedanib if required. Because chronic HP, I mean, we are going into progressive pulmonary fibrosis, there is no doubt, but even the GGs are increasing, so inflammation is going, so both combined can be given actually.
Dr. Uma?
Yeah, continuing on what the others said, I would first check if the patient is compliant with what I am giving. If I am immunomodulating, I would not stop that because I don't know if the process is going on. It is a chronic HP, but the inflammation may be going on. Like Dr. Hadda said, we don't have measures to check whether which process is going on or whether fibrosis has taken over. Without ground glassing, I don't think I'll start steroids unless it's an acute exacerbation. I'll keep the immunomodulation on, and if I have definite evidence of ongoing fibrosis like in this patient, I would add an antifibrotic. There's no open and shut answer, but we have to take it on a case-by-case basis.
Yeah, so we need to find out whether it is PPF despite treatment. So that is very important. So have we given appropriate treatment for the primary disease is a very important question. Many patients would have taken small little dose of prednisolone, 5 milligram or 10 milligram prednisolone for some time. So that is not a appropriate treatment for a HP. So we need to find out whether he has received adequate treatment, and then despite that, if there is progression in fibrosis, we are justified in starting antifibrotics. So next question is, when do you consider, question is he has progressed, so when do you refer for lung transplantation or when do you consider palliative care? Which side we should refer? I mean, based on patient's finances, definitely. Other than that.
Thank you. I'm glad you said with all these different components being discussed about pulmonary rehabilitation, oxygen, treatment, obviously there is progression. So it warrants a comprehensive needs assessment. So the recent European Respiratory Society has come out with a task force report. And one of the things they say is a comprehensive needs assessment needs to be done regularly. So in the needs assessment, they're looking for physical, psychological, social, existential distress, different sorts of needs. So unless we do a needs assessment, we will not know what is happening with the patient. So your treatment can continue. Again, coming to decision making, lung transplant is a huge decision making process. So there is a need for informed decision making, keeping all the ethical principles in mind. It shouldn't be like you just gave lung transplant as one of the options, like how you prescribed steroids. It's very different. So there has to be an informed decision making, and that needs to happen. So doing lung transplant is probably will give the best results, but that doesn't mean palliative care and its components go off. Both can happen simultaneously, so counseling, information needs should be met.
What Madam said, it should go hand in hand. And one small example, what I would like to say in transplant is, yesterday we had a patient who was same, except the age group was 28, who was a nurse from UK who is working in Papworth. So she is waiting for transplant for the last 3 years. So when we asked her, what was the reason, madam, what was the reason for 3 years you are waiting? So every time she tells that because of size disparity, I was not given the lung. So as you know, like what madam said, a transplant is a process. So any patient, once they go for a transplant opinion, they'll be evaluated for the risk factor and risk assessment will be done. And based on multiple other criteria and matching, the transplant will happen once there is a suitable donor if available. So transplant opinion and transplant assessment should be done along with the palliative care assessment, and patient should be advised to stay in the nearby center or stay in the nearby area, especially when the consideration for transplant is more. But it should go hand in hand, and everybody should know that it is not when somebody gets into exacerbation we should tell the transplant. Even when there is a evidence of progression and presence of pulmonary fibrosis, recurrent exacerbation, transplant discussion should be there, and they should be at least referred to a center. Whether it happens or listed or not, that's entirely different, but this option should be given at that time.
Okay, thank you very much. So we'll move to the last case.
So this is 55 years old, Mr. SKG, with a history of a cough for 3 years, which was non-productive, and exertional breathlessness for 1 year. With at presentation, he was having grade 3 MMRC with an effort tolerance of 100 meters, and loss of weight of 5 kgs in the last 1 year, which was unintentional. There were no other respiratory complaints, no CTD symptoms, and no exposures, and he was a never smoker. He had grade 3 clubbing, and he was saturating 96% in room air. There were bilateral basal velcro cryptations. His CTD profile was negative and echo was normal. His spirometry showed restriction, and which was confirmed with the TLC, and there was a drop in DLCO of 41%, and there was no desaturation at the time of his presentation.
So anybody can comment on the X-ray?
Open to all of this.
Yeah, open to all.
Yeah.
Would like to.
You can speak loudly, or I think the
Bilateral symmetrical reticulonodular shadow, same as we saw.
Okay, anything more you want to add?
Some cystic spaces might be there. I'm not sure on X-ray. So.
Okay. Anyone else wants to add anything, or everybody is okay with that?
Left upper zone could see some cystic changes. Left upper zone.
Okay. So cystic changes are also there in addition to the reticular nodular shadows. So what comes to your mind when you see these kind of appearance? So there are some kind of reticular nodular, then there are also some cysts which are seen confluent. I know the CT pictures are there, but still you can say. Compared to our previous reticular shadows, there are these cysts are the extra things, no? So is it LIP? Is it LAM? Is it LCH?
LCH.
Okay.
Because of upper
So in
lobe
LCH, okay, we will come to the CT. So we saw it's a 55-year-old. In which age group of LCH will you see reticular nodular opacity? It's before it becomes like cyst, no? It's much earlier, so that doesn't fit in. So that is not. So we know already this is a reticular nodular. It's in the ILD, DPLD group. So in that, which category will it fit into? So where do you see the cyst in the one of the common patterns we often come across? Cyst, cluster of cysts, where do you see?
Bronchiectasis.
That is cystic bronchiectasis. We are seeing more of reticular nodular. That is there already. Along with that, where do you see cyst? When I say cyst, cluster of cysts giving the appearance of Yeah, say it loudly because I may not be hearing everybody else.
Airway abnormality with fibrosis, maybe AEF, airway abnormalities with fibrosis can be there in the.
Okay, that is if there is also emphysematous with fibrosis, but in the fibrosing ILD, cluster of cysts, I'm not putting that word. Okay, before CPFE, where do you see the cluster of cysts? That's honeycombing, right? I'm trying to get that word honeycombing. Okay, because I thought just showing the CT, it will be much easier. If you see the CT, I know everybody will say, but I thought we can come to that diagnosis even on the X-ray itself. So remember when you see the reticular nodule, I agree with all the airspace. If you already have emphysema with honeycombing, you can think of CPFE. But here we know the history also, it was said never smoker. Not that you can't have emphysema, but we are not thinking in that line now. But we have these, what are these? These are the typical honeycombing. So honeycombing, that is cluster of cysts. The cyst size can even go up to 3 centimeter, that is by definition by the Fleischner's criteria. Of course, if there is also emphysema related changes, we can also call it as airspace enlargement or thick wall cysts as seen with CPFE. Now this is not CPFE, we are only seeing honeycombing, irregular reticulations, and where is it prominent? These are the basal sections. Maybe I'll show the axial to get the things more clear. So it's more in the basal sections. Okay, the larger cysts are more in the basal section. So what does it look like? So some of these cysts are actually quite big, isn't it? Certain. So, what do you want to call? If the anterior is more involved and the four corners, as I was talking about the CTD related UIP, only thing is I agree this in this the anterior aspect is more involved than posterior. Other findings of the exuberant honeycombing, the straight edge are not there. So just one sign, we may not be always be correct in saying it is CTD. I agree with what sir said, it had in the upper lobes, the anterior aspect was more involved than the posterior. And some of these were quite enlarged cysts, isn't it? So someone was talking about the CPFE also. And one more thing, what do you think about the rest of the lung? So when we see this, in this case, how was the was there a physiology-wise, was it obstruction? Only restriction, okay. So sometimes when we see like this, we should also, you can see the rest of the lung is relatively on the darker side, no? So we should also think of any obstructive component. So always the physiology, we should always correlate and see that also. So these are things which you should go through when you see these findings, whether if the background lung, how is it, is there any other component underlying, all these things you should look for, okay? So yeah, I think that's all in this case. And also look at the pulmonary artery. So here pulmonary artery is not dilated because all the fibrosing ILDs are prone for pulmonary artery hypertension, and also the upper sections of the abdomen also we should look for, is there any features of any other, sometimes there could be cirrhosis, so all those things, and also look at the esophagus, look for any dilatation, okay? And what do you think about this trachea? Yeah, the anteroposterior dimension, if it is more than 23, we call it a saber sheet trachea. So in this case, actually, along with the UIP features, there are some features to suggest an obstructive or an emphysematous obstructive airway disease in the background. Now, we also saw some of the airways being quite dilated also. So we can throw in the component of CPFE also when see such things, whether there is a component of emphysema with the fibrosis setting in.
So I have one question. Is the volume maintained, or there is a loss of lung volume?
There is no, here in this
because
case.
in X-ray also the lung look normal
Yes,
volume.
yes, that also
So-
is something when we don't see that also. Usually the regular UIP with IPF, usually it's a very, the lung volume will be reduced. In this case, if you see even on the axial sections, that's what I was saying, the lung attenuation is also quite a little more on the darker side, and it seems like the volume is preserved. So depending on which component is more, I think the spirometry will be highlighting that, but definitely that is also something we should look for. The typical IPF related UIP, we will see the lung volume would have started reducing by now with this much of UIP, the fibrosis present.
What is the final diagnosis? With this radiological picture of CPAP with UIP data, diagnosis is IPF. Are you happy with the diagnosis? CPAP.
Before that, I think we should rule out the secondary causes also. Yeah.
CTD profile was negative, and there was no history of, no exposures to suggest HB also.
ENA profile was normal?
Yes, extended CTD profile is negative.
So then it seems it is CPFE, combined
pulmonary fibrosis with emphysema.
Pulmonary fibrosis.
So it's a CPFE. So can we in this case the emphysema, if we look, there is a lower lobes. Normally we see in CPFE upper lobe emphysema with lower lobe fibrosis. So can it be other way around?
That's the real world for you. You will not see textbook pictures. If you see preserved lung volume,
Right.
with IPF picture, if everything else negative.
And what was the DLCO? Like in CPFE, FVC should be normal and DELCO should be so much reduced that we should get hint from the functional assessment.
That's what I'm saying. That's exactly what we are trying to say. What we showed you were textbook pictures. What the real world throws at you is this. So with that, you should be able to make a reasonable diagnosis. That's why the MDD. That's why all of us are sitting together and discussing what it is likely to be. Short of taking the lung out and looking at it, and looking at many parts of the lung, by which I mean autopsy, you will not be able to get the exact diagnosis. And we cannot do that in a living patient. So we can come to a reasonable diagnosis. That's what we are trying to say.
Here also, it is final also 14 years. FVC is FVC is almost 74%, but DLCO is just 40% or 46%. That indicates that volumes are preserved, but DLCO is out of proportion, going down.
Treatment-wise, how do you want to plan the treatments? Anybody else?
As there is no evidence of progression, no need of antifibrotics.
So he is telling since there is no evidence of progression, no need for antifibrotics. But we are calling it as a IPF phenotype. So here there is a role for upfront antifibrotics. IPF upfront antifibrotics is indicated. So you have to give antifibrotics, okay? One.
And based on decline in FVC and other parameters, lung transplantation whether
Lung transplantation that will come later before the medical management.
yes, sir. Antifibrotics and emphysema, bronchodilators and yes, sir. Rehabilitation and LTOT criteria if it is fitting. Yes. Vaccination. Yes. Yes.
And one more thing which you should do, which is a tip, is if your PFT is looking deceptively okay with this year, do not hesitate to go and do it again. Sometimes many of the values which you get will be extrapolated from the expiratory curve. They are just flown for 2 seconds. The machine will extrapolate it to 6 seconds and give you an answer. And your FEV1 by FVC will be normal for that second. So you have to go and look at the curve, actual curve. You have to see if the manure has been performed properly. And Kavita showed in the morning what prediction equation has been applied. Have the demographics been entered properly? Relook at the PFT if you have a discordance like this. You have preserved lung volume, so much lung damage, and PFT showing 72% FEV1, DLCU is impaired, something is wrong. Go and look at your PFT again. And maybe do it again. If you are residents, walk into the PFT lab and do it.
Someone mentioned lung transplant. Here the patient is not yet been started on treatment. For consideration for lung transplant, they should be on optimal maximal therapy for that disease and progressing despite that. So we are nowhere there here.
We are still struggling with diagnosis, which means all that we have done throughout the day is a waste. I'm sure he will also agree, isn't it?
We have to think early, but we have to think at the right time also.
So we'll close this session. Thank you very much. So over to Bani, Dr. Bani.
So as announced previously, whoever is interested in touring our facility, just gather outside in the corridor here. And it will only take 10 to 15 minutes, and the bus will leave soon after that from the chest pain unit, which is on the left of the emergency department. And then the bus to Big Bungalow, Bagayam campus leaves main campus at 6:30 p.m. from Asha building, front of Asha building. So please gather there. And tomorrow morning the buses leave at what time tomorrow morning? Ajish, tomorrow morning buses 7:45, yeah? Yeah, tomorrow morning buses leave Asha building 7:45 to reach here on time.